So this is the second part of the inguinal hernia topic. So in this I will be discussing about sliding inguinal hernia, some diagnostic features and treatment. So it is a form of inguinal hernia in which a mesoperitoneum organ or structure that slides down the posterior abdominal wall and herniates directly or indirectly into the inguinal canal. So in this sliding inguinal hernia, there will be protrusion of the mesoperitoneal organ or any kind of structure of the mesoperitoneal organ which slides down the posterior abdominal wall. So this will be in this diagram earlier I have shown you. This is the posterior abdominal wall. So it can slide down through this, and in this there can be directly or indirectly. That means it can come through without entering the deep inguinal ring, and it will be coming directly to the superficial inguinal ring, or it can be coming through the deep inguinal ring and the superficial inguinal ring both. So these two things we can see in case of sliding inguinal hernias. So if it is present in the right side, then in most of the cases cecum and ascending colon will be involved in the hernial sac, while if it is present in the left side, then sigmoid part of our colon and descending colon. So sigmoid colon and descending colon will be involved. So this is the main difference between both sides hernias. So mainly the left side is quite more common as compared to the right side, and sometime portion of bladder can also slide. So portion of bladder can also slide through this part. So if we will see the, you can say, differentiation or classification by genesis and by mechanism of development. So by genesis we will describe it into congenital and acquired, and mechanism of development we will divide it into indirect and direct. So indirect is quite rarely, because it is difficult for the mesoperitoneum organ to slide through both of these structures. So it is quite rare in case of sliding inguinal hernia. Indirect is quite rare, while direct is quite common, because it will be easier for the mesoperitoneal organs like sigmoid, descending colon, cecum and ascending colon to just directly protrude through the posterior abdominal wall and enter the superficial inguinal ring. So it will be quite common. So what are the clinical manifestation in this case? Due to hernial protrusion, the organ involved can be affected. So the organ which is involved can be affected. For example, if these are involved, then there can be, you can say, constipation can be there, and there will be increase in gas can also be there. Abdominal distension can also be present. So the organ which is involved, the symptoms will be according to that organ only. For example, here see, dysuria will be present if case of involvement of bladder. So if bladder is involved, there will be painful urination or difficulty in urination. And tympanitis or meteorism, that is basically increase in the gas in the you can say our bowel. So and also constipation in case of large bowel involvement. So these we can see in case of large bowel involvement. Uncommon dull pain is also present at the localized site. So what are some other diagnoses? So main diagnosis in case of these inguinal hernias is physical examination. We have to see how the patient is clinically presenting himself, and also hernial bulge palpation and percussion can also be done. Contrast enema can be done in case of sigmoid and descending colon inguinal hernias, and bladder catheterization and contrast cystography can also be done in case of if bladder is involved, urinary bladder is involved. So these are the main things that you need to know about inguinal hernias and diagnosis, some of the diagnoses. Now we will come to the main important part for inguinal hernias, that is the treatment. So treatment, if we will see, surgery is the main treatment for inguinal hernias. So there is no escaping from surgery. Like you cannot take tablets for hernia. Surgery is the ultimate procedure that you doctor have to do to treat the hernia. So what are some pre-operative preparation? Like we have to prepare the patient for the surgery. So some pre-operative preparation must be done. For example, we must correct the fluid and electrolyte balance in that patient. Also elimination of some factors like which can lead to increase in intra-abdominal pressure. For example, constipation, we can give laxatives in these cases. Chronic cough, we can give some cough syrup or some other treatment. Urinary obstruction also we can treat, for example, using catheterization and other method. So we have to do some pre-operative preparation before really going for the surgery. Then second, we will do the anesthesia. So anesthesia can be local in case of small hernias, but it has to be general in case of large and irreducible hernias. So surgical access is mainly open hernioplasty or laparoscopic hernioplasty. So this is the main surgical access that we will use in case of hernias. So what are the steps of open hernioplasty? So we will read about every hernioplasty method in detail, but here just see the overview. So in first stage there will be oblique incision parallel to the inguinal ligament. We will make a oblique incision just parallel to the inguinal ligament, just 2 centimeter above it. So just 2 centimeter above the inguinal ligament we will be making an oblique incision. Then we will dissect the aponeurosis of the external oblique muscle. We will be dissecting this aponeurosis of the external oblique muscle, and we will open the inguinal canal. So this is the first stage. Second, there will be preparation of the hernial sac from spermatic cord. That means the hernial sac is separated, or you can say it will be just putting apart from the spermatic cord and surrounding tissue. It will be put up. High ligation and amputation of the hernial sac is done. So it will be you can say pull up. It will be pulled up. High ligation and amputation of hernial sac is done in second stage. In third stage, suture and narrow external and internal links until normal size. Because hernial sac is protruding, as I'll show you here in this diagram again. So when the hernial sac is protruding through these two rings, so they will be dilated. So we have to narrow them and suture them appropriately to bring them to the normal size. So the normal size is usually 0.8 centimeter in most of the cases. So this will be the normal size, and this is the third stage. And the fourth stage we will do plastic repair of the inguinal canal by using mesh. So this mesh can be aponeurosis of the muscles itself, or it can be some extra, you can say, foreign material, for example proline or dacron, etc. These kind of meshes can also be used. So now we will learn about surgery in detail. So when we open the inguinal canal, we use mainly two methods. One is tension method, another is tension free method. So what is this tension and tension free method? So in tension method, basically we will do the autoplastic repair of the inguinal anterior wall and of the posterior wall, but we will be doing this repair using our own body muscles or own body aponeurosis. So these are the tension methods, because we will be pulling some aponeurosis of the muscle and we will be holding, or you can say ligating them with the inguinal canal. So in this there will be tension will be present. So these are the tension methods, while tension free methods will be, for example, we are not using our own body aponeurosis, the prosthetic repair is done from external you can say mesh or some other sutures or some prosthetics. We will be using the repair of the, or you can say we will be doing the repair of the inguinal canal. So first of all, autoplastic repair of the inguinal canal anterior wall. So we will see about the anterior wall here first of all. So in this anterior wall case, what we will see, that suturing of aponeurotic muscular layer to the inguinal ligament. So our own aponeurotic muscular layer is sutured to the inguinal ligament above the spermatic cord. So above the spermatic cord it is sutured. Then suturing and narrowing of the inguinal canal is done. Both of the rings will be sutured and narrowed, as I have told you earlier also, till 0.8 centimeter it is done. Then the strengthening of the inguinal canal external and internal ring. Then the anterior wall of the inguinal canal is strengthened by the help of aponeurotic duplication. So the anterior wall of the inguinal canal will be strengthened by using muscle aponeurotic duplications will be done. So this is the main method of the autoplastic repair of the inguinal canal anterior wall. So mostly it is preferred in case of small and middle indirect hernias of children and young patients. So small, middle, indirect hernias of children and young patient, it is mostly preferred this type of method, this autoplastic repair of inguinal canal anterior wall. And commonly used, you can say, autoplastic repairs, or these are some operation names that you have to remember. These can be Girard Spaso-Kukotsky, Girard Spaso-Kukotsky, or Kimbravosky repair, or Rovi-Opel repair. So these three names you have to remember for this autoplastic repair of the inguinal canal anterior wall, and it is mostly preferred in case of small, middle, indirect hernia of children and young patient. Now the second method is otoplastic repair of the inguinal canal posterior wall. So in this we will do the suturing of the aponeurosis fascia and muscle to the inguinal ligament under the spermatic cord. So in anterior wall we have done it above the spermatic cord, but in case of posterior wall method we will be doing it under the spermatic cord, and formation of new course of spermatic cord is done, and narrowing of the internal ring, only internal ring is narrowed in this case up till 0.8 centimeter. Strengthening of the inguinal canal anterior wall is done with the help of aponeurotic duplication. So this is same as the earlier. So most commonly it is preferred in case of large indirect direct sliding and recurrent hernias. So in case of large indirect direct sliding and recurrent hernias we will be doing this repair. And commonly types of inguinal canal you can say posterior wall aponeurotic repairs we will do in these operation will be done. So they will be Bassini repair, Shouldice repair, McVay repair, and Kukozanov repair, and post-Kempsey repair, and Lothensin repair. So you might see some Russian names here, as I already told you that I am making these notes from the Russian literature of my university, so you can see some Russian literature also, but I have tried to write some English literature also according to love and belly, so you can see these also. These will be Bassini repair, Shouldice repair, McVay repair, and Lothensin repair. And so this is the everything that you need to know about these two methods. Now the third method, which is the prosthetic tension free repair of the inguinal canal. So in this we will be applying synthetic non-absorbable prosthetic mesh that can be propylene or Dacron, I already told you earlier, and also some biological prosthetic graft can also be used, example Duramater, broad fascia, so these can also be used. So in case of inguinal canal prosthetic repair, most commonly used methods will be Lichtenstein and Voskerensky-Gorelick. So Lichtenstein and Voskerensky-Gorelick are the most common method used in inguinal canal prosthetic repair. So what we will be doing in the case of this prosthetic repair? So in prosthetic repair we will be first of all removing the hernial sac. The internal ring is narrowed by the help of the suture, as we have done earlier in both the methods, but in this case without using the aponeurotic duplication we will be using prosthetic mesh. So prosthetic mesh is applied under the spermatic cord and aponeurosis is done. So anterior wall is sewed side to side without aponeurotic duplication, so we will not do aponeurotic duplication. This prosthetic mesh will be applied under spermatic cord and it will be used for the aponeurosis. So this is the third method. So except this method, now there is another method, for example laparoscopic hernioplasty. So laparoscopic hernioplasty can be done in case of very large hernias, recurrent and bilateral hernias which are present on the both sides. So laparoscopically it can be treated. So there are two approaches we can say. One is transabdominal pre-peritoneal approach, another is total extraperitoneal approach. So transabdominal peritoneal approach, total extraperitoneal approach. So in both of these methods hernial sac is not removed. The hernial contents are just reduced to the abdominal cavity and hernial ring is closed by the help of mesh from inside. So we will be applying mesh from inside and it will be closing the hernial ring. So this is all about laparoscopic hernioplasty. Now recurrent inguinal hernia. So in case of recurrent inguinal hernia, if it is occurring again and again, it is, what are the main reasons for this? It can be inadequate post-operative preparation. For example, after doing all these surgery or any of the above surgery, and post-operative preparation are not good. Like for example, the patient does not take care of himself properly, and also the doctors are not you can say telling him that he has not to do some stress work or something like that. So that can be the case in one scenario. And also in recurrent inguinal hernias, direct hernias are more common, or you can say have more chances than case of indirect hernias. And also another reasons can be post-operative wound infection. In case of post-operative wound infection can also be recurrent inguinal hernia. Also in cases of prostatic adenoma, chronic cough, etc., these can also be some cases. So what is the operation type that we will do in recurrent inguinal hernia? So repair will be done under tension and does not heal with adequate protection. So this is not the operation type. This is basically the, you can say, the cause. So in case of tension, the repair which is done under tension, the aponeurosis which we have done, it does not heal with adequate protection, so that is also leading to the recurrent inguinal hernia. So the main operation that we will be doing it, we can do laparoscopic hernioplasty. It is an indication in case of recurrent hernias, and we can also do this autoplastic repair of the inguinal canal prosthetic wall, as in this also the recurrent hernias is an indication. So this is everything about inguinal hernias. I hope you understand it quite well. Thank you very much.